The ED is the front line for identification of a patient that is presenting with sepsis. It is vital that we screen every patient that comes through our door using our ED or our sepsis screening tool, despite of what their chief complaint is when they come to the ED.
After early identification of sepsis, it is imperative that you draw a lactic as soon as possible.
Identify the source, and do so through the use of chest x-ray, LP, blood and urine cultures, and UAs. And try to do so before antibiotics are administered.
For each hour you delay antibiotic therapy in your septic patient, you increase the risk of mortality. Oftentimes you'll need multiple antibiotics to make sure you get good broad spectrum coverage.
According to the Surviving Sepsis campaign, a patient who is hypotensive or has a lactic of greater than 4 will require a bolus of 30 mL per kg of crystalloid fluid.
If your patient isn't responsive to that initial fluid bolus and your mean arterial pressure is less than 65, go ahead and start some vasopressors and get the physician in at bedside to do a reassessment.
It is very important to repeat a lactic acid level within 6 hours if your initial lactic acid was greater than 2.
The best way to stop sepsis is early detection. How we do that is by using Cerner ad hoc form, the sepsis screening tool. Please make sure you're doing this on admission, once a shift, and PRN with any patient changes and a new infection.
What's even better than completing the Surviving Sepsis bundle? Preventing sepsis. Most infection is spread through contact, either person to person, often with dirty hands, or through the environment. So remember the importance of good hand hygiene before and after each patient contact, and clean medical equipment between each patient.
For the survival of the septic patient, communication is key. From early identification to protocol initiation and beyond, let's work as a team to help our patients have better outcomes.